So for many years we have asked for more data and especially more randomized data for LAAC, and now we have it. We have a very recent publication, actually 2 publications in New England Journal of Medicine, one with, I believe, a positive signal, and the other one maybe with not so positive or maybe a little bit negative signal. And also what has happened during the years are more and more ablation going on, and especially we have now PFA, a technology that probably is more safe than prior methods of ablation, and there's a lot of patients being sent to this treatment. And we also have 2 very interesting trials addressing can ablation therapy lead to stroke prevention. So it's a pleasure for me to introduce Tom DePotter. He's a highly recognized invasive electrophysiologist working in Belgium, and Tom, you will dive into the ALONE-AF and the OCEAN trial.
Absolutely. Thanks a lot, Jens. Erik, let me check something. Yes, so I'm very much still working in Belgium indeed, not in the Netherlands. I don't know why that's on there. I do speak Dutch though. No, you were right, it's wrong here. As Jens Erik already introduced, 2 interesting trials were published in the space of AFib ablation and stroke prevention. The background to all of this is, of course, that first of all, what you need to remember if we're talking about stroke prevention in the AFib ablation population, you need to realize that the background stroke incidence is low. This is data from more than 10 years ago already from European registry, where you can see that in our AFib ablation population, the incidence of observed neurological events is pretty low. And this is, of course, due to the fact that, especially then, but nowadays still very much so, a lot of the patient population that we treat is very low risk to experiencing clinical strokes. There is some argument to be made, of course, that there is more than stroke. There's good data, for example, one study we did using apixaban, evaluating apixaban, where brain imaging was performed exhaustively, where we were made aware of the existence of these phenomena, which are called silent cerebral lesions or silent cerebral emboli, not necessarily translating to stroke, but of course phenomena you'd rather not see in your patients. And again, in this study, as with all the NOAC trials, we saw that first of all, NOACs are capable of reducing these phenomena, and stroke rates are low to begin with. Now, the other 2 interesting questions for the purpose of this presentation are, and they are related, the questions are, is AFib ablation a sensible strategy to prevent stroke, and is stroke prevention still needed after AFib ablation? So, is AFib ablation a sensible strategy? Historical opinion seemed to say no. This is, again, more than 10 years old guideline recommendation. Already saying that you should absolutely not do AFib ablation to restore sinus rhythm for the purpose of avoiding anticoagulation, despite the fact that this is actually what many patients come for. Many patients, especially outside of the paroxysmal cohort, come to you, and if you tell them, well, you'll still be on anticoagulation after the ablation, they look at you and they're a bit confused because they thought that was the goal of the procedure, that was why you were there. And also in the recent 2024 guidelines, quite clearly, although without data, class 1 level of evidence C recommendation, quite clearly the guidelines say that you should not discontinue anticoagulation after an ablation based on the fact whether you think the procedure was successful, yes or no. However, intuitively, it makes a lot of sense to say if we cure the atrial fibrillation, why should you to ongoing stroke prevention. And all these recommendations fundamentally are based on opinion. There is no was no definitive data. What we had was retrospective data and smaller prospective studies, and they were actually supportive of the hypothesis that you can safely stop anticoagulation, that you can reduce the stroke risk by ablation. And this is a hypothetical curve. This is not a data curve. This is a hypothetical curve illustrating the idea that if a patient that receives an AFib ablation most likely has a stroke risk which is similar to an AFib ablation who is anticoagulated. And this revisits a bit what we learned 20 years ago in the AFFIRM trial, where we said, okay, it's not so important to have patients in sinus rhythm, and apparently there's not much impact on stroke. If you look at the data, that's not true, of course. If you look at the sub-analysis of AFFIRM data, the patients in sinus rhythm obviously did much better, and the patients that stayed on warfarin obviously did much better. A lot of patients in AFFIRM were taken off warfarin because the procedure was perceived as successful, and it was actually not. So the debate becomes a bit anticoagulation after ablation. Do you believe that, yes, indeed, atrial fibrillation causes stroke due to the traditional mechanism, the triad of thrombosis, which is universally present and also present in the left atrium, leading to clot formation and stroke? Or do you believe more that atrial fibrillation is more a marker of atrial disease, of atrial myopathy, of potentially systemic vascular disease? And in that case, of course, the AFib ablation will not necessarily fix the stroke risk. As mentioned before, we dive in the data. Historical observational data strongly supports the notion that patients with ablation have pretty much the same stroke risk as patients without atrial fibrillation, no matter what the CHA2DS2-VASc score. If you compare cohorts, you will see in these large databases that patients without AFib and patients with AFib with ablation have the same stroke risk, and patients with AFib without an ablation typically have a higher stroke risk, regardless of their baseline risk. And so, based on this, two studies were performed. First of them, the ELAACC trial conducted in Korea, randomized clinical trial, where patients were selected that received catheter ablation for atrial fibrillation as their initial procedure, not necessarily a single procedure, and were at least 1 year after this procedure. No upper limit defined. Procedure may have been 5 years ago. Maximum age for the ELAACC study, 8 years old. Patients were then screened to make sure, to verify that they were indeed considered successful ablation recipients by two Holter recordings of 1 to 3 days to confirm they were in sinus rhythm, and then they were randomized to either continue anticoagulation or to stop completely their anticoagulation, and they were followed with Holter recordings every 6 months for 2 years. Here's the patient flow in more detail. 840 patients randomized in the ELAACC study. Not too many protocol deviations, not too many crossovers. Baseline characteristics of the patients, you can see that about a third of patients is in persistent atrial fibrillation, which is considered potentially a more advanced disease state, certainly if you think about this atrial myopathy hypothesis, which is potentially a sicker patient profile. And you can see that despite the relatively low numbers, that ELAACC did not have particular important exclusion criteria. Pretty much all comers were accepted. And even patients with previous stroke, although only 5% of patients in the data set were randomized into the study. What the results of ELAACC very clearly show is that for the primary endpoint, cumulative incidence of stroke, systemic embolism, and major bleeding, the primary combined endpoint, you can clearly see that continuing anticoagulation has a worse outcome, has a significantly worse outcome than stopping anticoagulation in patients with successful ablation. And you can also see from the secondary endpoints that this is predominantly, I would say, exclusively driven by a difference in bleeding risks, which makes a lot of sense. You can see that in terms of Stroke reduction, it doesn't matter much. Again, the baseline risk for stroke is low in these patients to begin with, and obviously if you keep patients on anticoagulation, they will experience a bleeding risk. The other equally important and very similar trial, which was published the beginning of this year, is the OCEAN trial. The OCEAN trial, again, recruited patients that received the catheter ablation for atrial fibrillation. Again, at least 1 year after their procedure, and again, no upper limit on the duration of how long this ablation should have been in the past. Again, a cutoff on age. Both studies avoided recruiting very old patients, although OCEAN was a little bit more liberal in that it allowed patients up to the age of 85 years. And OCEAN did exclude patients who had a recent stroke defined as a disabling stroke within 1 year of enrollment, or any stroke within 2 weeks of enrollment. And also, OCEAN excluded patients with end-stage renal disease in their design. Just similar to ELAACC, OCEAN screened patients with Holter recordings to verify that they were indeed in continuous sinus rhythm before randomizing them. And then slightly different to ELAACC, where in ELAACC anticoagulation was stopped. In OCEAN, patients were randomized to receive either aspirin, low-dose aspirin daily dose, versus rivaroxaban at the reduced dose of 50 milligrams, regardless of renal function. OCEAN did study not only clinical outcomes, but also imaging outcomes. OCEAN pre-specified MRI imaging at baseline and at 3 years, specifically to look for these silent lesions, of course, and had a 3-year follow-up. In OCEAN, a little bit over 1,000 patients were randomized, 1,284 patients. Again, you can see from the patient flow charts that protocol violations and discontinuations were favorable, that most patients were able to adhere to the study protocol and complete the study until the final visit. You can see in the baseline characteristics of the OCEAN trial that, again, about 1/3 of patients has persistent or long-standing persistent atrial fibrillation, 2/3 of patients paroxysmal atrial fibrillation. And you can see, probably due to the slightly different design of OCEAN, the slightly more, well, not slightly, the clearly more stringent exclusion criteria of OCEAN, that few patients had a previous stroke, although again it was not specifically excluded, provided the stroke was long enough in the past. The primary endpoint of OCEAN does not include bleeding, only includes stroke or systemic embolism. So here the survival curves are a bit different, but they give the same message, being that discontinuation of anticoagulation, rivaroxaban in this case, was not inferior to a strategy of aspirin alone. And OCEAN, of course, did report on bleeding events. It did report in its paper on bleeding events, where you can see that there is a slight numeric, although statistically not significant, difference in bleeding events, both of them low, a little bit higher in the rivaroxaban group versus the aspirin group. Comparing both trials, you can see that the designs are fairly similar. The geographies are a bit different, which may matter in terms of stroke prevention and bleeding tendency. OCEAN was done in 56 centers in 6 countries. ELAACC was performed in South Korea exclusively. Enrollment similar, around 1,000 patients. And you can see the median LAACC score in both trials, also relatively similar, not the highest stroke risk population. You can imagine a mean of 2.2 in OCEAN, a median of 2 in ELAACC. ELAACC doesn't report the calculated mean value of their LAACC score. And with respect to their primary outcome of stroke prevention, of ischemic events, you can see that OCEAN reports 1.4% of ischemic events on aspirin versus 0.8 on rivaroxaban. And you can see that ELAACC reports 0.3 with no therapy versus 0.8 on DOAC, which is both the equivalent outcomes, and you can see that the penalty lies in bleeding, especially in the design of ALONE-AF, where due to the fact that one of the randomization arms is no therapy whatsoever, and ALONE-AF reported 0 bleedings, so have a 0% of major bleeding rate versus, of course, a low but not negligible 1.4% of bleeding rates on DOAC. Ocean reports a very similar DOAC major bleeding rate of 1.6% versus a residual bleeding risk, as we're all familiar with, on aspirin of 0.6%. So what does this mean for stroke prevention by ablation? First of all, I think the risk factor versus risk marker debate is not settled. Remember the data we received from the ASSERT study. The ASSERT study clearly looking at subclinical atrial fibrillation events in pacemaker patients, the ASSERT study clearly showing that this intuitive concept we all have, a patient has atrial fibrillation and develops a clot in the appendage and develops a stroke, is not necessarily true if you look at our patient population that is monitored continuously, which is our pacemaker population. In the ASSERT study, we quite clearly saw that this linear temporal relationship between AFib and stroke is not always true, on the contrary. NOAA, AFNet6 and Artesia, the 2 studies on subclinical atrial fibrillation, also did not make life easier, I think, with their mixed message on stroke reduction versus bleeding risk increase. But the 2 studies just shown, Ocean and ALONE-AF, do confirm safety of either no treatment or aspirin alone after a successful ablation. So I think the key takeaways for this space are, first of all, remember baseline stroke risk is low in the AFib ablation population. That's very simple. We don't treat a patient that is in the Closure AF study. We don't treat such a patient with AFib ablation. That is not the patient profile that we see in our labs daily. And this is a historical observation. And this is a shared signal which is confirmed in 2 randomized trials. There are some clinically relevant differences between the trials. So first of all, one trial has no treatment as the comparator. The other trial has aspirin. On the other hand, the ALONE-AF trial did not do any imaging, just looked at clinically evident strokes and used Holter monitoring alone for follow-up. But in general, I believe the takeaway is we now have 4 strategies for stroke prevention after AFib ablation, which are studies in randomized trials. These strategies are LAAC closure, DOAC, aspirin, or no treatment, as studied in the option trial, the ALONE-AF trial, and the Ocean trial. And based on the individual situation your patient is in, I believe we can offer them any of these options, given considering what might be most appropriate for that patient. And finally, remember, reassuring is that in all groups in our entire AFib ablation population, the annual stroke rate remains low. Thank you very much.
Thank you, Tom. It doesn't matter. Let's stand up. So, for any comments now, questions from the audience, Adele.
Sorry. I'm invasive cardiologist, you're EP, so when I see the data from the 2 trials, I see that there was a very selected population when you could ensure that there was a very low risk of AF recurrence, if I understand well. They did Holter and they checked the Holter again before randomization. And so to what extent, when you select, as an EP, when you select this kind of patient, you are sure that the rate of recurrence is low, so you can provide that kind of downgrade in the antithrombotic treatment. So you know what I mean? It's like if
Sure.
they're highly selected and you ensure that you have no recurrence, you can go for that.
No, it's a very relevant question. So what the trials did was they waited 1 year. They waited 1 year, and then after minimum 1 year, and sometimes longer, in many cases longer, Then they did Holter screening twice to confirm or to maximally assure that the patient was indeed in sinus rhythm. Now, that gives you a population that is reasonably safe to assume that for the near future, this will stay the case. This does not mean that this is a population that will stay without symptoms for the next 10 years. And this is, for me, it's one of the big open questions, is what do you do? The trials don't answer this. If this patient, you see him 1 year after ablation, everything is fine, you stop the anticoagulation, and another 18 months later, the first recurrence is documented, I guess we'll restart the anticoagulation. But this is an open question. The trials don't answer this. What they do is they give you a good argument to doing something which, frankly, many in the EP community are doing already, which is not to anticoagulate the low-risk population indefinitely after a procedure which is perceived successfully until that time where you document the recurrence, which is easy to do in the paroxysmal population, which is sometimes tricky to do in the asymptomatic population.
What was in the protocol? Was there any action required in the protocol if these if a patient got atrial fibrillation within the trial?
I'm sorry, I missed the first part of the question.
Was there anything in the protocol? Was there any action required? So, of course, low-risk patients. But then if these patients had a relapse and they had atrial fibrillation, there was no anticoagulation required then?
No.
Or were there any? So they were off the whole time?
Yes. No, if a patient that has a recurrence of atrial fibrillation until now, for lack of better evidence, receives anticoagulation again.
James, you have a question?
Yeah, so it was interesting. I saw a tool presented on this on Ocean at the AF Symposium in Boston, and he said that in his opinion, this applied to anyone with a CHA2-VASc score of 3 or less. And there was only about 20% of the patients that had a CHA2-VASc score of 3 in the study, and then a very small number with 4 or greater. And I have to say there are a number of challenges associated with this. I couldn't agree more. Your point about it's a highly subselected population. But it's also people, we know recurrence rates occur in 30 to 50% of people. Who are you applying this to in your practice right now? I mean, I would agree with you. We basically just use it as confirmatory for our very low-risk patients if they do well after AF ablation, but it hasn't really broadened what we're doing otherwise.
No, I agree with that. And so it applies for us in our practice to the majority of our patients, which are still the low-risk patients. We still have not moved extensively to treating very high-risk patients, which translate, the CHA2-VASc score is not meant to determine a patient's risk for a procedure, for example, but it does translate. Like many things, you can use the CHA2-VASc score for many things it was not designed for. And so if you end up looking at our database at who we actually ablate, there's not that many CHA2-VASc 4 or more patients that we select for ablation. And so what we use this trial data for is to strongly confirm what we were doing already. So 0, of course, was off anticoagulation always. Patients with CHA2-VASc1 were, in our practice, typically suggested to stop anticoagulation after successful ablation based on the equipoise that was already there in the guidelines, right, with the CHA2-VASc1 score. These two trials now strongly confirm that it's probably actually the wiser choice to do that. CHA2-VASc2, based on the trials we see, that are published, will now also get this suggestion where historically they did not. So we have shifted our threshold from CHA2-VASc1 to CHA2-VASc2, everybody. CHA2-VASc3 becomes, I don't have an algorithm for you, becomes an individual discussion with the patient.
And it's, I mean, also important to remember that not all CHA2-VASc score points are created equal.
Exactly.
Right? So mild essential hypertension, female sex, not the same as somebody with heart failure.
Exactly. Previous stroke, for example, although they were in the trial, I can't see myself doing it. And you can have a previous stroke CHA2-VASc 2 or 3, unusual, but they are there. It's absolutely right. And so the Chazwa score is an opaque general marker of potential cardiovascular disease. I couldn't agree more.
Laura, you have a question?
Yeah, there is a couple of points that I want to remark. First thing is, as Adele was saying, this is a very selected population of more or less healthy patients, so we cannot extrapolate that to all the patients with AF ablation. And probably in this very healthy population, they will not also a closure of the appendage at the same time. That it's other of the topics that we are touching. And probably we go back in the time for these patients as patients without any atrial fibrillation, so we need to just do a surveillance of them, and if another AF episode comes, we decide at that moment. But the other important thing is that in most of the studies of the EP groups, there is a lack of information regarding the anatomy of the atrium and also the anatomy of the left atrial appendage, because we are still looking at the anteroposterior diameter of the atrium for a lot of EP guys just to decide if they do the ablation or not. And we don't have like more strong markers of left atrial disease. So probably if we can combine this maintenance of the sinus rhythm with a healthy atrium, probably we can say that those patients are not at risk. So maybe it's something just to think forward.
I have no argument with what you're saying. As you know, we've also contributed to data trying to analyze, to do simulations of flow dynamics in the left atrium to exactly via one mechanism try to understand what you're hinting at, which is that in some patients and some anatomies, stroke risk may be very low no matter what. And this is why I showed this assert data. It's not because you have AFib that your stroke risk is the same as another patient with AFib. And this whole idea is not necessarily proven, is not necessarily correct that you have AFib and tomorrow there will be a thrombus in your trabeculated appendage. It remains speculative. There is no answer to your question. And the observation we have, and this comes back to the first part of your comment, and that's why I showed the first slide, is today the bulk of our patients we treat are very healthy patients. We treat them because we believe we can cure them from their atrial fibrillation, which excludes the vast majority of patients which you see, for example, as a potential LAA candidate, which are typically patients far beyond hope of restoring their sinus rhythm. Having said that, there is a lot of data emerging, for example, in heart failure, showing benefit of PV isolation in heart failure patients, which has led us to treat sicker patients. And especially in that population, I do think the concomitant story makes sense, because especially in that population, there is at least a subset where you think the probability of recurrence is going to be high and the probability of future issues is going to be high. And it makes sense where you need to do it at the time of the procedure or later is a debate for another session. I guess you can argue about that. You might do it in 2 sessions. But it is shifting a bit. Until now, however, our patient population is extremely fit and healthy and unlikely to experience stroke no matter what.
Hi, Tom, Joël. Thank you for your presentation. So you demonstrate that after atrial fibrillation ablation, you can stop anticoagulants because the risk of recurrence is so low in your population. So based on that, is there still a space for combined procedure of LAAO plus the first atrial fibrillation ablation? So do you consider first attempt of AF ablation, then stop anticoagulant, and if recurrence after 1 year or 2 years, then consider LA occlusion? Well,
so that's exactly the sentiment I also have. You're absolutely right that well, I didn't necessarily show that the risk of recurrence is low, but it is fortunately low in our healthy patient cohorts. It's not that low in the long-standing persistent cohort, but there you can argue whether you should ablate them. But having said that, yes, I agree that the debate, should you do an LA closure at the time of PV isolation versus in a second session, merits arguments for both sides. The argument to do it concomitantly is, of course, one exposure to risk, one exposure to procedure, which is not an invalid argument. The argument to do it sequentially is precisely like you say, especially in the patients you think are likely to respond, you wait. And this is the OCEAN and the lone AF population, I think, is the population where you wait. The CHASVA 0, 1, 2 population, you do the ablation, you wait. If they have recurrence, you can discuss LA occlusion if there is a patient profile that warrants it. The very high CHASVA population, which today I don't think we're treating a lot of them, especially not in Europe, but we are treating more of them, where for whatever reason you think the probability of AFib recurrence is high, I think the argument for concomitant is still not 100% do it, but we shouldn't throw it out of the window. But I think the European practice validates what you're saying. We don't do that much concomitant.
I mean, there's also the high-risk bleeding population, right? So, I mean, someone who can't wait a year because they have cerebral amyloid angiopathy, they just have incessant GI bleeding, those people are other candidates that we think about it for.
Exactly.
Hassan?
So the recurrence of AF measured by the 24-hour tape and 48-hour tapes, or is it because I thought AF burden is more important than detecting just a few episodes of a few beats of AF? First question. The second one is, do you think it's the most in clinical practice, it's 10 to 12 weeks that you tend to stop anticoagulation, but this trial extended to 12 months. What's the rationale behind this?
So the first part of your question, the detection of recurrence, the Holter screening that was done in the trials, first of all, was to confirm eligibility, was to confirm was the AFib ablation successful? This open question, which in clinical practice will hopefully mean one Holter for most of our outpatient clinics. Is Holter the same as burden for stroke risk? That's an unanswered question. The simple answer is if you do more screening, you will find more AFib. If you give everybody a loop recorder, clearly you will find more AFib. And this is, in part, it's not exactly what Artesia and AFNet6 studied, but it's in part what they studied. The question then becomes, what do you do with these potentially subclinical AFib episodes? Are they the same stroke risk as clinically overt AFib? The answer from both trials is if you anticoagulate those patients, as you would intuitively expect, you gain stroke reduction at the expense of increased bleeding risk. Lorenz.
Tom, very interesting talk, thank you. I have one question that is challenging me a bit. So you said that in the current AF guidelines, there's class 3 to stop DOAC after ablation. And then we have 2 trials that you have presented that actually suggest that you don't need it. But if you look at the event rate, it's extremely far away from being powered for ischemic stroke. So you would probably need 10 times the number. So now we are confronted with a situation where on the one hand, the guidelines say class 3. On the other hand, you have 2 massively underpowered trials that indicate that you could do it. So what would be the conclusion now? I mean, I understand it's clinical. Clinically, it makes very much sense not to give, not to continue DOAC in patients who have no recurrency. But still, there is this dilemma, I would call it.
The current guidelines, so the class 3 recommendation is from more than 10 years old, is not to do AFib ablation for the goal of stopping anticoagulation. The current guidelines, they do the wording the other way around. They say you should not stop anticoagulation after AFib ablation only because you believe the ablation was a success if the patient otherwise has indications for stroke prevention. And so it becomes a class 1 indication because the wording is reversed, level of evidence C. With this new data, if I were on that, well, I was on that team, but if I were on it now, I think I would say you can revise that statement now. We have data to revise that statement. I agree with you, not to a wording, stop anticoagulation in every patient after successful ablation. But now you can make a statement such as data supports discontinuation of anticoagulation in patients with an appropriately low risk profile for stroke after successful ablation. And that is 2 randomized trials. That's level A. Jim, what do you think?
Can I just comment also, your point about the underpowering for differences is appropriate. That said, the absolute rates were extremely low and well below the threshold that we would often think about for initiation of anticoagulation. So I think it's reasonable to use those absolute numbers rather than having to show a difference that's relative, that's powered appropriately. So that's, I think, how things will shift in the EP community based on the absolute numbers. I mean, the numbers were staggeringly low in OCEAN. Including the fact that they did MRI looking for silent cerebral events. I mean, almost unbelievably low.
Maybe, sorry. Maybe I can add something as an electrophysiologist as well, because I have a little bit of a provocative idea is there is no study out there yet that has shown that doing anticoagulation post-ablation is actually something good to do, because I think each ablation kind of resets the AF burden that we have in these patients, and it's a completely new situation. And so far, we didn't have any data. Now we have OCEAN, we have lone AF, we have also the data from OPTION, and at least in low-risk patients, it seems reasonable to stop it. But on the other hand, we always assumed that we do something good, continuing anticoagulation, but actually never knew so far. That's the first time we have data on this.
One more short question, Tom. What is your view on repeated ablation procedures? Is this something you will only consider for the first time ablation, or if a patient come back and need a redo procedure, are you still...
Would I apply alone AF and OCEAN to redo?
Yes, to redo cases.
It's an excellent question. The study actually did not, the study population is that population. It did not say patients could only have had one ablation. Like many of the elements, so again, TRANSVAS 0, 1, no discussion, 2, probably no discussion. The higher it goes, the more these soft elements come into play if you do your discussion with your patient. For example, a patient with multiple redos, it's obviously more likely that the patient will have a recurrence. And so there it becomes less of a solid statement like we're sure, we're convinced that you're fine and we're convinced that it's fine to take you off anticoagulation. Less so. There is no black or white. It's a balance, but multiple redos for me would be an argument leaning towards continuing anticoagulation.
Thank you very much. There will be also, after the next presentations here, we will finalize the session with poll questions to try to get some consensus, so we will have more time for discussion, but I think we'll proceed.
Yes, and I will swap places with Erik, because there's more data than just post-ablation patients, and Erik will take us through the Champion AF data.
Can you put up the slide? Thank you. Yeah, so very recently we saw the Champion AF trial research published in New England Journal of Medicine. They were initially presented at the ACC and then a co-publication in New England. And we all know about the background for this study. I think all in the room appreciate that left atrial appendage closure is an important option for stroke prevention, because we have many patients out there that simply cannot tolerate long-term anticoagulation. But as you know, the Champion AF is about, can we broaden out this stroke prevention concept to a broad AF population where patients can actually be put on DOAC treatment and are suitable for long-term anticoagulation. That is the purpose of the Champion AF. And it's a large study, as you see, 3,000 patients were randomized. They had, based on TRANSVAS 2 for males or more, or 3 or more for females, intermediate to moderate increased risk of stroke. And they were randomized 1-to-1 to LAAC with Watchman Flex or to DOAC treatment. The post-procedural regimen in the trial was predominantly full-dose DOAC in the first 3 months. 85% had that regimen, and then 15% had DAPT. And after 3 months, all antithrombotic or the initial antithrombotic treatment were changed to just single use of aspirin for 1 month, and then the follow-up imaging was done. So it's also the first trial where you do the follow-up imaging after de-escalation of the post-procedural treatment. Also importantly, the study here is designed for follow-up during 5 years, and the initial publication here is related to follow-up after 3 years, and we still have also to wait at the 5-year data in this trial. Primary efficacy was a combined endpoint of cardiovascular death, stroke, and systemic embolism. And some would criticize the inclusion of cardiovascular death. This was simply also a criteria from FDA, and also looking at some of the prior LAAC trials, there has been a signal actually towards lower cardiovascular death with LAAC, so this is completely relevant. And then the whole concept of LAAC is about reducing the bleeding risk for patients to have them off DOAC. So of course the safety endpoint here is related to bleeding. It's non-procedural major and clinically relevant non-major bleeding, and this endpoint was tested for superiority. You all know about the major bleeds. The non-major clinical relevant bleeds here were a modified one. Actually, the criteria for the bleeding severity was strengthened a little bit. Those bleeding episodes are episodes that require either hospitalization or some kind of healthcare intervention. The design or the non-inferiority margin has been discussed a lot based on the time where the trial was planned. The estimated rate for the primary endpoint was 12% in each group. It turned out to be down to 5 to 6%, so much lower. One of the explanations is that almost 50% of patients in the trial had ablation. But the non-inferiority margin was set to 4.8, and power calculation showed the requirement for 3,000 patients. And of course, there were some dropouts during the trial course, but it ended up with 2 large cohorts for intention to treat analysis. And you can see, first of all, with the HASBET score, it's low, it's 1.3. So it's not a high bleeding risk, it's a low bleeding risk population, and you can also appreciate that more than 60 to 70% were actually between CHA2DS2-VASc 3 and 5, and almost 20% more than 5, so there's also a good amount of patients with a high stroke risk in the trial. And again, if you see the lower line, almost up to 50% had ablation. The procedure was very successful, carried out with 99% success. And if you look at the complication rate in this large randomized clinical trial with many centers enrolling patients, it's really good data. You can see we have a complication rate around 1%, only 0.6% effusions, no device embolizations, no mortality, only 1 periprocedural stroke. So I think it's very, very good data that we now have a very safe interventional procedure that is not more risky than PCI ablation or other things we do in the cath lab. If we look at leak rate and degree of sealing, it was also very good with almost 99% having a complete seal or less than 3 millimeter leaks, only very few leaks between 3 and 5 millimeters. Then we have a reported total DRT rate of 4.8%. This is a mixture of TE and CT evaluations, and especially CT evaluations contributed to this number because all layerings on the atrial side of the device being 3 millimeter or more was counted, but you can see that only in 1.8% those changes led investigators to treat for DRT, and also if you look at the very high risk DRT, like the pedunculated DRTs, the number here was very low, and only 2 patients had stroke associated with diagnosis of DRT. And then the primary endpoint, you can see 2 curves that are almost completely overlaying here. You have to zoom in to detect any differences, and there is a slightly higher number of primary efficacy endpoints in the LAAC arm, 5.7% versus 4.8%. This is a difference of 0.9%, and it's highly away from the initially defined non-inferiority margin, which could have been as low as down to 2.6, and still we will get a significant non-inferiority signal. If we look, this is not reported in the paper, if we look at per protocol analysis, the numbers are even, or the difference is even smaller. Then the primary event rate in the DOAC arm is 4.4%, and it's 4.7% in the LAAC group, so it's down to 0.3%, so it's even smaller. So if we look more on a breakdown of the primary endpoint, we can see that cardiovascular death is the same, and as we all have noticed, there is a little bit or numerically higher ischemic stroke rate in the LAAC arm. We have 50 cases, and we have 33 cases in the DOAC arm, including also 2 systemic embolizations. So this translates into an annualized rate of ischemic stroke systemic embolism of 0.8% for DOAC and 1.1% per year for LAAC. But a stroke is not a stroke. A stroke can be very disabling. It can be much less severe. And most of the strokes in the Champion AF trials were actually non-disabling. And if you look only at the disabling ischemic strokes, which is what really matters in daily life, I think, then we have 13 disabling strokes in the DOAC group and 19 in the LAAC arm. So the difference is 6 patients out of a cohort of 3,000 patients followed over 3 years. So that is not a huge difference, I think. And what is also interesting about this study is probably the study where we have the highest degree of adherence to the DOAC. We had 87% of patients in the DOAC arm that adhered to the therapy. So it's a very, very high rate. Primary safety endpoint, that is major and clinically relevant non-major bleeding without procedural bleeds. I will rapidly go to this slide because I think that's probably more fair and more reasonable to look at, because this also includes the procedural bleeds. And you can see initially during the first 6 months there is a higher rate of bleeding in the LAAC arm due to inclusion of the procedural bleeds, but you can see after that the curve starts to separate and you have a huge difference at 3 years of 19% versus 12.8%, and you can see the continuous separation of the 2 curves over time. So looking only at major bleeds, again, remember this is a low-risk bleeding population, has bled 1.3, so there's not many major bleeds, but they are out there as well, and you can see again a little bit higher in the LAAC arm initially, but then numerically more also major bleeds in the DOAC arm compared to LAAC. If you try to put this a little bit into context with the stroke rates and look upon some of the previous LAAC versus DOAC trials, this is actually all stroke rates you could separate into ischemic and hemorrhagic, and you know from the PROTECT AF we also had more ischemic strokes in the LAAC arm, but it was equalized by less hemorrhagic strokes. So total stroke rates, PROTECT AF prevail, PRAG 17, option even closure AF and champion AF. You can see that the stroke rates are quite similar whether you go for mechanical LAAC or you go for medical treatment with DOACs. Okay, there's one slide missing, but I think we also have to mention here that the ischemic stroke rates in the large pivotal DOAC trials, they were 1.1% and up to 1.7%. So it's actually the same stroke rates we see in those large trials than we see in the champion AF LAAC arm. So this is a large trial of LAAC, and it has demonstrated non-inferiority to DOAC in this composite endpoint of stroke, systemic embolism, and CV death. At 5 years, we will have a separate analysis on just ischemic strokes and systemic embolism. It might be the case that more patients on DOACs will lose their adherence in this period, and it might contribute, I don't know, but we'll have to see, to more ischemic strokes in the DOAC arm. I think what is very clear is that we, with LAAC, get much less bleeding. And I was amazed to see that in a low-risk bleeding population with a has bled 1.3, we have 20% of patients having bleeding episodes over 3 years. So it's a very frequent problem in daily life for AF patients taking DOACs, and we all know that that is one of the main drivers for non-adherence if patients run into bleeding episodes. So LAAC may be considered as an alternative to DOAC in a shared decision-making process with AF patients who are deemed actually suitable for long-term DOAC. We can discuss that if the data will allow us to do this in clinical practice. And again, we'll see more data after 5 years. Thanks.
Thanks a lot, Jens Erik. Anybody wants to offer any comments or questions or insights? Sergio.
Congratulations, Jens Erik. An excellent presentation of the trial. So probably the data from Champion are helpful to identify the correct target population for the ELAACC closure. Just a comment from you, your interpretation on the ischemic stroke, the difference of the ischemic stroke between the two arms.
In my perspective, I think the stroke rate is very low in both groups. And I think in clinical practice, we can never achieve near 90% adherence rate with DOACs. So I think in real life, we would see more ischemic stroke in the DOAC arm. So I think it has been highly highly, I think, overemphasized in the discussion. This is 6 patients that differ if you look at disabling stroke. So I don't think of course, you can also think about what if ischemic stroke rates were equal in the 2 groups. Then we would have a trial that was a completely home run, and we could discuss LAAC as a first-line therapy. No, I think it is a modest difference, and I think in my own practice, I would not sit with a patient and inform about, okay, here we have 0.3% difference between this and this. I think with all the data we have, when we look at also the LAAC versus STOAC prior trials and on the pivotal DOAC trials, I think I would make the interpretation that the stroke risk protection is similar between the 2 strategies, and where the difference is in the bleeding risk. But this is something, of course, we can discuss. So is that a real signal, or is it just statistical variation?
Jens Erik, I think it's very important to mention that what we have in Champion, as you said, is the best of LAAC with this expert center, I would say, first-line expert center. You mentioned the very low number of complications and the best of anticoagulants with 90% adherence, which is absolutely not what we see in real life. So coming back to this stroke difference that you mentioned, you talked about the per protocol analysis that shows that we have less disabling stroke, and especially with the per protocol analysis. What about the bleeding? Because I think there's something with the bleeding that is, that is quite bizarre. Is about this non-peri-procedural bleeding, you know. But if we want to be fair, you have to add the peri-procedural bleeding. And if you look at the per protocol analysis, what is the difference between the serious bleeding and the total bleeding?
The breakdown to the disabling stroke numbers, that is still the intention to treat analysis. So the company didn't release all the details about the per protocol analysis yet. I just have the total numbers, which was 4.4 versus 4.7%. But the reason why I think the procedural bleeding is separated from non-procedural bleeds, I think you can easily argue that it's 2 very different things. Having a bleed, being in hospital, where a lot of the bleeds are growing bleeds, and that's one-time bleeds that can be managed when you are in hospital. It's very, very different from getting a bleed remote to your procedure after half a year, maybe suffer gastrointestinal bleeding. And one more thing, I think this Kaplan-Meier way of looking at bleeding endpoints probably is not completely the right one, because what we see in clinical practice is typically, let's say we get a patient with a gastrointestinal bleeds, and it might be treated surgically or something like that, and then we as cardiologists really aim to put this patient back on DOAC, and then we very frequently see they come back with repetitive bleeding. And also, what can happen many times if you have a bleeding event that will lead to stop of anticoagulation, that's the other route, and then it will lead to more ischemic stroke. So in some way, I think the Kaplan-Meier way to look at bleeding underestimates actually the bleeding problem. So one consideration is maybe to count all those bleedings that occurred during the trial and talk more about the bleeding burden. That could be relevant. And I would also like to have that as part of if you do cost effectiveness analysis, because one of the things that can really support LAAC if we can come up with some of the expenses for those patients that are going to the hospital, emergency units, etc., with those repetitive bleedings. So I think it's very important. Kaplan-Meier sort of underestimates this issue.
Jens?
Claudio.
Yeah. I really agree with the concept of the bleeding burden. Probably just makes the difference. Before we listen to the closure AF, I think that we need just to point out some difference between the two studies. Number one, the Champion AF obviously recruited a younger patient population as opposed to the closure AF. Number two was implanted just the Watchman. While on the other studies, just that we have different devices implanted. This, probably we need just to take into account. I do really think that the message, at least for me, from the Champion AF, that probably the best way is just to intercept patients at the earlier stage. Otherwise, you might, end up to have a different clinical outcome. This is probably what we need just to, take the message home from the Champion AF.
I strongly agree with this statement, and I believe that's the way to go to intervene earlier in the disease process. But Carsten will, in a minute, also go through the closure AF, so we will have that in details. But also one comment regarding the procedural bleeds, because Champion AF full dose NOAC as the principal way to do post-procedural medication, but I think that's always more or less historical, because now we know a lot about DAPT associated with very high bleeding, and we have very intriguing data about just the use of half-dose DOACs or single antiplatelet therapy, and we have the first device. This was Watchman Flex, not Watchman Flex Pro, and Watchman Flex Pro might also allow us to minimize the post-procedural regimen even more. So I think also the procedural bleeds with just our development of the therapy and the post-procedural medication, that will help us to reduce the amount of procedural bleeds. And I believe also we still have some leaks. And James also pointed out that even small leaks can contribute to a thromboembolic risk. And I mean, the next generation device from Boston and from other companies with the Amulet 360 and the lead device from Boston, they are sealing better, or they are designed to seal better and to also cope with this issue. So there will be this continuous improvement in device technology.
Yeah, really, truly, just the fabric is important and critical. I would like just to have a clinical trial by using a half dose of the DOAC. I think that we need that data.
Yeah, that is very important, but as you know, there will be for the Watchman Flex Pro, we already finalized randomization of 1,000 patients having single antiplatelet, dual antiplatelet, or half-dose DOAC. So that will come out probably TCT this year, so we will be guided more.
Congratulations for the authors for this important study. I hope this will have an impact on changing some guidelines, especially European guidelines, and it is important trial for the community. The question I have is, when they decided the number of event rates, if they thought the event rate would be smaller, would have needed a higher power. So do you think if we had more patients, the results would more favor LAAC than the DOAC? Because 12% versus 4%, that led to the inferiority margin of 4.8, isn't it?
I'm not sure I got your point fully.
So it's regards to how did you decide the inferiority margin? based on the 12%
Yeah.
event rate.
Yeah.
Because if the event rate, what we observed was very low.
Yeah.
So if we initially thought that this group of patients will have low event rate,
Yeah.
the number of patients we would have recruited, the power calculation would have been different.
Yeah, you had to have more patients.
Patients.
Yeah.
So would that have delivered a better outcome for LAAC? Because maybe the difference that what we are seeing may be due to the low number of events.
Maybe because, I mean, the numbers for strokes are so small that they are easily explained by just statistical variations. And I think looking at the other trials would suggest that this could be the case. But of course, we need to see that. But I hope the 5-year analysis will be helpful in answering this question.
Please, we have one more. Okay.
Erik, so some of the non-believers of LAAC closure could also argue that even in the Champion AF, which is a very contemporary trial with expert centers, the rate of DRT is still rather high, even with 3 months DOAC therapy after implantation. And so if you believe that we could go a step down on anticoagulant therapy after LAAC closure, even with these rates of 4% DRT, what is your opinion on that, except for the newer generation devices that are being developed, which may help us in the future, but still in a low to moderate risk patient population, like in Champion AF, we still need to address this DRT rate of 4% to convince the community that it's a safe therapy.
I fully agree, and I would say we are not free of the problem of DRT, as also seen by those numbers. But I would say that there has been a lot of confusion out there in diagnosing DRT because it is problematic and not extremely easy to discriminate natural healing of the device with real DRT. And I can say that when the imaging protocols were created for this trial, there was not, for instance, the HAD classification and definition of what's going on the atrial side of the device. That was not available, and it was analyzed according to the initial image protocol. So I'm quite sure that there will be a sub-study diving into the details of this. Was it just, had class 1 changes in the majority of cases, and was DRT cases diagnosed falsely, reality seeing natural device healing? And I think that will be part of the explanation, especially when you see only 1.8% reacted and actually put the patient on treatment for DRT. So I believe it's overestimated, but the number is still out there, and we need to do it better. But we also need to come out with details on that analysis, because if you really have 4.8% as real DRT, that is a bad signal.
Very briefly, and then maybe last question from Claudio. What is your practice, Erik, very briefly? Is it CT or TE?
That is cardiac CT.
Yeah, thank you. And thank you for raising up, this issue, because I do really, I'm afraid that not, the DRT so classified in the Champion AF was really, thrombus, because it depends if you use the CT, it's much more, sensitive than the TE. And therefore, I hope, I'm pretty sure that probably the rates of DRT are much lower than what, is reported in the clinical trial. Sometimes it's really difficult to distinguish industrialization of the device, as compared to a real thrombus.
And you can very easily have 3 millimeters of layering on the device that just continue to the LA wall and across, and it's just a matter of very nice healing. So, yeah.
All right. Thank you very much. And in the interest of time, we do have one other very interesting piece of the puzzle, one last very relevant recent trial, which is of course Closure AF, and it's our pleasure to invite Carsten Skurk to present on the trial.
Yeah, thank you very much. I figured that there is a lively discussion, and therefore I will just present the data, and then we can discuss the trial. So originally, you see, DZHK trial 16. It was designed in 2015. It's investigator-initiated, prospective multicenter in 42 centers in Germany. It was conducted, and I can go over this. So basically, we know evidence in 2015 was even worse than today. Basically, we thought at that time that it is really important to have a trial in a high-risk population, because that was a population we actually did LAAC in. These were the patients that had a high stroke and high bleeding risk, because then they are not eligible for bleeding, and we should discuss bleeding in regard to closure. And so basically, then the other thing we thought, of course, investigator initiated, we don't have the power of big companies, so we have to conduct a pragmatic trial, and that's why this combined endpoint, that was one part of it, and the other part is, and we discussed it today, of course, major bleeding in this patient population is relevant, and therefore it is a good endpoint. So endpoint: stroke, ischemic or hemorrhagic, systemic embolism, cardiovascular unexplained death, and major bleeding, according to the LAAC classification. So how were the patients selected? Schatzwask, larger or equal to, an increased bleeding risk according to Hasbled, not the best characterization, but there is clinically no better one, larger equal to 3. A history of major bleeding according to BARC, history A to C, and renal insufficiency was the third parameter, eGFR 15 to 29 milliliter per minute. Patients on hemodialysis were not allowed into the trial. So these patients were randomized to catheter-based left atrial appendage closure with devices that where results were published with more than 500 patients, so basically Amplatzer and Watchman, or physician-directed best medical care. We figured, okay, these are high-risk patients that might not have DOACs, so that's why best medical care. Primary endpoint, the composite of stroke, systemic embolism, cardiovascular unexplained death, or major bleeding. And originally, it was planned at least 18 months follow-up. In the end, we were at minimum of 6 months follow-up, and I will tell you why. So the trial was originally designed as event-driven with an expected event rate of 11.2, and that would, we expected 1,586 patients in the trial with a non-inferiority margin of 1.3. Just as comparison, Prevail had 1.8 and Prague 1.5. So this is a really tight non-inferiority margin for an interventional trial. Then there were 2 planned interim analyses that we conducted, and we found, these were blinded of course, that the event rate is higher or was higher than expected, and therefore we could change the design to less patients, and then PRAGUE 17 came out with another event rate, so that we were pretty sure that we had enough events to close the trial, and it was ended in November 2024. We would have liked to present it with a presentation at AHA, but there were some unforeseen problems with, I can talk about later. So, what was the peri-interventional therapy? That's really important at that time in Germany, and I would say before closure was published, 60–70% of centers, that is 3 months stopped, and aspirin until 6 months. If there is no other indication for aspirin, if you had excessive bleeding risk, then you could go down, and these was just a recommendation to 6 weeks of DAPT and aspirin up to 3 months. In the best medical care group, it was advised to give DOACs if the patient was eligible for this therapy. So 912 patients were randomized, and we see 446 were randomized, were included in the primary analysis in the LAAC arm, and 42 in the best medical care arm. And patients were therapied as one, got the therapy. 93% in the LAAC arm got an LAAC, and 85% in the best medical care arm were treated with a DOAC. So basically you could say, well, actually it's a trial intervention against DOAC. So with these inclusion criteria, we were quite surprised which patient fulfilled these. So basically 80-year-old, 40% females, but a Schwarz-Warsk of larger than 5.5 split of 3, but look at the other characteristics, major bleeding, almost half of it, status post major bleeding, and a stage 4 chronic kidney disease, 1/4 of these patients. So really high-risk patients for stroke and bleeding. And here we see the medication. So basically, adherence was quite good. You see the DAPT got off after 3 months, but, and that's interesting in this age group, not surprising, approximately 70% of patients received aspirin over the whole period, and that's a point for discussion. In the best medical care arm, we see, if you want to have that, a really good adherence in this high-risk bleeding group to DOACs, because basically 70% of these patients took DOAC during the whole time of the trial. So mean follow-up was 3 years, maximum follow-up was 6.7 years, so quite good. And then the other question is, of course, 42 centers in Germany. These were all experienced centers. How good is the quality? And I saw the registry data, and it's basically the same. It's quite the same age, and we have technical success of 98.3% with these older devices, but procedure success is good as well, but a little more leaks than Champion has, but 3 major leaks in the LAAC group. Of course, if you have high-risk patients, you have a higher complication rate. As you can see here, 5.7% is almost double as much as you would have expected. Major bleedings, okay, all the devices, but we have a device embolization and 2 deaths due to pericardial tamponade in these patients. So you know the event curves, and what you may not know is that as farther you go out, over 4 to 6 years, this is great territory because a lot of patients died or are censored. So there's event rate that could be by chance. You see that the curves narrow and then separate again. And then, of course, ITT analysis and per protocol analysis look the same. 16.8 events versus 13.3, and this means that LAAC is non-inferior to best medical care in this patient group. Why do I say that? Because we did not pre-specify a test for non-inferiority. So premier, it was planned as a non-inferiority trial with a second test for superiority for LAAC. Good, then the other question is, okay, non-cardiovascular death is the same in both groups, pretty much, and we see here the event rates. And you can appreciate that basically, except for ischemic and hemorrhagic stroke, these event rates are more often determined in the LAAC group compared to best medical care. So basically, it's non-inferior because you have more events of the primary outcome in the LAAC group. And we just want to thank all the people who contributed to the successful completion of the trial that took twice as long as we originally planned. And I have some slides for the discussion, but maybe we should start.
Kasper.
First of all, great achievement, Carsten. It's very impressive to do investigator-led studies, and I don't think we all know how hard it is, so congratulations on that. On a second note, if you calculate, it's 10 procedures per site across many years. Do you know how many procedures that were done at each site? Because this is not an all-comer study.
Right.
This is a selective population, and the indication, the inclusion criteria is pretty much the only indication we have at the moment.
I know that is one critique of the trial, but in general I would say we tried our best to recruit more patients, but there are several aspects to it. So first of all, of course, in Germany we do more LA closures. This patient population is actually the patient population LAAC is done in, or was done, let's put it this way. And the other one is that hospitals lost half of their patients if they recruited into the trial. And I guess that was one reason why recruitment was lower than we expected. That is first of all. Second of all is then COVID came, and we had 6 months pause of recruitment in the trial, and afterwards it was really slow coming up again. So there are several issues with recruiting. I guess no trial recruits as expected. Yeah, so finally with these high event rates, otherwise we would still recruit patients. We could go down with a patient number and had the statistical power still in the trial.
Yeah, Carsten, a question. How that trial change your, let's say, looking at the patients which are now in your center, let's say, selected for the LAAC closure? I am asking that because in my practice that trial changed not so much. But in many Polish centers, many of patients are now, based on the results of the trial, excluded for the LAAC closure because physicians who are not directly involved with LAAC closure are using that trial to say that it's harmful to perform the LAAC closure because these patients are too sick. So what's your strategy in your center? Does the trial change anything or not?
Yes, of course. We have a trial which I think is of high quality, and that shows that if you do LAAC as done in the trial, then it might be harmful to the patients. So what are we doing? We are more critical in selecting the right patients. And that is one thing. Can I have the slides up again, please? And the other thing is, of course, the peri-interventional antithrombotic regimen. So as soon as closure was done, so I don't give DAPT anymore. But then, of course, okay, this is randomized data. Can you have the slides again? I just want to show. So the good thing is, of course, even in this high-risk population, and we saw Champion and we saw Option, even in this high-risk population, the LAAC is doing what it's supposed to do. This is really important. So if you speak about bleeding, I don't know any randomized trial that could prevent major bleeding. And Philip said that, and so it's never has been shown in any trial, LAAC versus anything, that major bleeding is significantly reduced. Non-procedural, yes, but if you take all major bleedings together, there's no trial that shows that, except in the Marcumar era, vitamin K antagonists. And the same happens here. So if you look at bleedings and you just exclude these 18 major peri-procedural bleedings, it might have been non-inferior. And if you look what happens within the first 3 or better the first 6 months, because data capture is a little bit slow. So after 6 months, you have only 50% of major bleedings in the LAAC group. So it might be that in Champion, 5-year follow-up will for the first time show that major bleedings are reduced in a randomized study. So as long as you wait, as better it gets, even in closure. Although, and that's the other discussion, this is time to first event. So repeated bleedings are not in here, and we will do an analysis with all endpoints in the trial. Experience tells you that that is not really different, but since ischemic and hemorrhagic stroke have low event rates, this might be really a difference in major bleedings because they appear quite often. So this is one thing. So if I have a closure patient, and there are, I don't want to show you all these slides, there are some data out that imply that it's safer to use other regimens, half-dose NOAC, single antiplatelet,
much better than dubbed without any harm. Although there's a selection bias in these registries because, of course, people with a really high bleeding risk or active bleeding get these medications, and these are few people, and stroke rates are really low. So yes, we are more critical in this patient group, and we would do another peri-interventional antithrombotic regime.
Javi, you had a question?
Yeah. So for me, it's really surprising the control group, the high rate of, DOAC plus aspirin, DOAC plus DAP. So it was like 90%. So if I imagine, my population, the patients that I treat, that, mostly are, like patients with previous major bleeding, like yours, I cannot imagine just that these patients would accept, just to go back to the medication that causes a major bleeding. So my question is, in that sense, there was a selection bias to select patients that maybe could tolerate, the anticoagulants in the, in general, or you dismiss, the patients, with very.
I don't know. No selection bias. There are inclusion-exclusion criteria, and then the patient get into the trial. And of course, you would select really few people, and that was when we, applied for the grant for closure. How many contraindicated DOAC patients are there really, was the question, in all these fields, right? And so we see champion adherence 90% over three years. Surprising, because NOAC trials had adherence rates 70, 60%, 70% over 2 years. Not a high bleeding risk population. And these are the data. So I can't tell you, but I wouldn't say it's a selection bias because people wanted to give DOACs. It just tells me that we overestimate how well DOACs do.
Yeah, no.
That's my opinion. If I see these data, I wouldn't have expected it.
Yeah. One thing that is of concern to me is the mortality rate. The yearly mortality rate is 14% in this trial, and cardiovascular mortality is the primary driver for the difference between the groups. And my point is here, you are probably very, very advanced in the stage of the AF disease. So can you really, with an interventional procedure, change anything, or they are just dying from other causes? And I can tell you that we went back and looked at our mortality rate in our Danish cohort, and it's 2.9% per year in those we are treating with LAAC. So that is 3% versus 14%. So it's extremely different, at least to what we are doing in Denmark. So.
Yeah. We did not go back, look in our cohort, but I'm quite sure it's lower as well. Yeah, these are 80-year-old patients, and 80-year-old patients. So in the States, 78-year-old or 76-year-old have 8% mortality per year. So so this is a little bit higher, and that argument, of course, that people die a lot in the trial, in both groups, for whatever reason. There is a small signal for more cardiovascular death in the occluder group, but that could be by chance. So that's the other problem with these patients, right? So overinterpretation. So I would say, okay, they die at the same rate, which is high, but still before they die, they have events, and these events are distributed in a way that is disadvantageous to LAAC.
Thank you very much, Carsten. I think we need, you cannot leave the room because we need to do our poll questions here and try to see if we make some kind of equal interpretations about those trials. So can you please get us the poll questions for session 3? And you can only do one voting per question. So you have to choose the question that you feel is the best, or the answer that you feel is the best answer to the question. So let's see if we can get the set of questions up here. And we also need Tom to vote yes. So based on the ALONE-AF and OCEAN trials, will you be ready to skip anticoagulation post-ablation in AF patients, CHA2DS1 to 2? So there's a clear signal here. 75% says yes. Okay, it's not finalized. Okay. Why is only we have only we have a total votes of 7 only?
I think it is people who complete it, because you can fill in all the answers and then send, right? So I think we can go over the questions, and then in the end, you have to press send, right?
Okay, so you are answering all the questions now, yeah, okay.
And I think it means we have 10 complete answers now, right? Is that correct? Okay, I guess we can go to the next question. We have 16 complete already. So based on the ALONE-AF and OCEAN trials, will you be ready to skip anticoagulation in patients with prior stroke, regardless of CHA2DS1 score? It's a pretty clear answer, I think. Nobody seems to be ready to do this. And let's go to the next question. If you do skip anticoagulation, how would you monitor for recurrent AF? Apple Watch or similar? Majority of responses. Holter at regular intervals, implantable ECG recording, or symptoms, no systematic monitoring. This is an interesting result, I think.
Yeah. The friendly way to monitor for patients.
Well,
yeah.
This is a very interesting result. It's not what was being done in the trials that were performed. It's definitely not what is being done in clinical practice in the CHA2DS1 1 and 2 population, not by a long shot. Probably a good way to monitor patients, but not what is happening in practice.
Still getting a few responses. Yeah. Let's take the next question now. Based on the Champion AF results, will you consider LAAC as a reasonable alternative to DOAC in a shared decision-making process? Majority says yes. Still only got 36 votes, or is that what we can expect? Yeah, maybe. Let's go to the next then.
Let's move to the next question, please.
And that's for people that do not consider LAAC as a reasonable alternative with the current data. And there are different arguments here. more data, wait for the data after 5 years, and still concerns about the stroke rate difference, and some wants to wait for the catalyst to have more randomized clinical data. Okay, let's move on to next question. The Closure AF trial enrolled relevant LAAC candidates and failed to demonstrate non-inferior to standard medical care, and we should therefore forget about LAAC. That's also a hard question. So yeah, I'm glad we have a clear answer here. So should we see the next question? Can you move on to the next? Yeah. The Closure AF trial can guide us to determine which patients should not be selected for LAAC in clinical practice. And I'm a little bit confused about the bar that I see here. So it should be only... okay, they move to... there's some confusion here. Oh. And
this is the question, if you believe that closure should be used for patient selection, by which parameter. So I think the majority voted, and slightly more than half identifies patients at high age with high degree of comorbidity, yeah. Right?
But we really missed the correct question for one thing here. But okay, we don't have more time, so thank you very much for the input, and then let's proceed to the session 4.